Welcome to AETCM, the Emergency Medicine Channel. So today we're going to talk about an young patient who came with complaints of headache 2 years.
Okay.
Initial primary assessment, patient was conscious oriented in the first 10 seconds. So we started with the airway. Patient is talking in one full sentence. There were no secretions in that, so airway appears patent. Breathing wise, patient was having 20 breaths per minute with saturation of 98% on room air. Bilateral air entry was equal with no any significant external muscle activity.
Okay.
Next, coming to circulation, patient was having heart rate of 90 per minute and BP of 200 by 120. At this point, 2 large IV bore cannulas were put in and we sent for ABG and all preliminary examinations. And coming to disability, GCS was E4, V5, M6. Pupils were 2 mm bilaterally reacting. Coming to exposure, temperature was afebrile, GRBS was 100 mg per dl. And regarding the pain score, she was complaining of bifrontal headache with pain of 8 by 10. So at this point of time, 1 gram paracetamol IV was given. And after paracetamol injection was given, reassess the BP. There was no change in BP. Right now, BP was still at 190 by 110 mmHg, sir.
Okay.
So at this point of time, we can going to the secondary adjuncts to the primary survey. VBG was showing no acid-base disorder, but in VBG potassium was 3.3 milliequivalents, sir. And no lactate was normal, no other any abnormalities. So because of persisting headache with high BP, initial CT plain brain was we sent for radio imaging of CT plain brain.
What is there in your mind when you are asking for a CT scan?
Usually patients coming with thunderclap headache, such kind, we have to suspect subarachnoid hemorrhage.
Okay. Only when there is a bleed, you can pick up by CT scan. So that can be done when there is a high BP with severe headache. Can BP itself can produce headache?
High BP, persistently high BPs can cause head discomfort as in headachehness, but not as in persistent.
Okay, sometimes that depends on the patient. We cannot tell. All patients may not have, like chronic hypertensives may never complain about headache. Acutely, if the BP is increasing, then you can get headache, dizziness, heaviness of head, all these things.
Sir, so during the secondary survey, sir, patient has no any allergies, sir. Next, coming to medicines she was on, she has not taken any medication, no known comorbidities as of now, and past history wise, she's been diagnosed with hypertensive 6 months ago, for which for 2 months she had taken hypertensive medication and she stopped taking. But she had delivery 1 year ago. During delivery, there was no any pregnancy-induced hypertension, no any such history was there. Regarding to the events leading, the patient had complaints of headache, nausea and left upper limb tingling sensation since yesterday, sir. Patient, the pain started in left frontal area and was diffuse in nature. Patient gives a pain score of 8 by 10 and patient even complains of early morning headache at around 3 am, which was on and off for last 6 months she was having. Okay. She is a administrative executive as in the office, and there were stress related, anxiety related issues going on regarding the work even. That is the events.
Is it tension headache or a headache induced by hypertension? What is tension headache? Those who are having heavy tension, they also can have a headache.
Yeah.
Is it hypertension induced headache or tension induced hypertension with headache? What is this tension headache? Is it similar to this headache? Huh? What is the character of tension headache?
Usually it is a band-like.
It's a band-like heaviness all around the head. Okay, cluster headache.
Cluster head.
There are different causes for headache. Hypertension is one of the cause. Cluster headache is not migraine. What is cluster headache? Cluster headache, suddenly patient get redness, watering of eyes on one side, severe pain. That is cluster headache. Migraine?
Migraine is consisting like aura can be with aura, photophobia.
With or without aura can present.
Episodic kind of a nature with having some triggerings.
Okay. That is mostly unilateral headache associated with vomiting. After vomiting it may subside. There may be some triggers, all these things. Okay.
So initially, the CT which was taken had no any bleed on the CT. Sir.
Okay.
Regarding further workup, patient's headache reduced. Even by giving paracetamol, her pain score hadn't improved much. So we had given her tramadol, the next line of pain medication. With the help of tramadol, her pain had subsided, but the BP had been persistently high of 160 by ATM Hg, sir. So further evaluation.
Can we give NSAIDs in hypertension-induced headache? Yes or no?
Yes. But to say,
What is the action of NSAID on BP? NSAID, steroids, all these things have same action. What is the action?
Increases.
Increased? It increases BP by what? What means?
Renal.
Vasoconstriction is not that. What happens to the water and sodium in kidney after giving NSAID or steroid?
Collection increases.
Retention of water and sodium. Okay. So that itself can increase the BP. So NSAIDs are not a good choice in hypertension-induced headache. It is always like you told, paracetamol or tramadol, whatever it is. Non-steroidal anti-inflammatory drugs are not indicated, or it may be contraindicated in hypertension-induced headaches.
So further regarding the workup in this patient, as the patient was having hypokalemia in the initial, like a patient as it's a 37-year-old female patient, as it's an young patient, first we have done an ultrasound renal artery Doppler to rule out renal artery stenosis.
So that's okay. You have a patient with a high BP. His potassium is somehow low in your first report.
Yes.
So what are the things you will address in this patient? What are the investigations you do in this patient?
Hypokalemia with increased BP, we have to consider primary hyper.
It is not always like that. It is not a must that they should have primary hyperaldosterones. Which all conditions you can get hypokalemia with hypertension.
Secondary to renin
That is the only reason you know. Suppose you are not taking potassium-rich diet.
Yes.
You have hypertension. What will happen? What will happen? You are not taking anything. You are not taking proper food. But you have hypertension. You can have hypokalemia.
Yes. But yes, we can workup.
So what is the workup?
We have to consider urine spot potassium and urine osmolality and serum osmolality.
Before that, you have to ask some questions to the patient. What are the questions you will ask to the patient when he is having a hypokalemia with hypertension? What is the commonest cause for hypokalemia in your practice? Vomiting. Drugs. What drug? Which drug? Lasix. Okay. The diuretics are the common cause for hypokalemia. So you have to take a detailed history whether the patient is taking diuretic or whether the patient is taking adequate food. All these things are important. Okay. So this patient is not taking diuretic. This patient is taking normal oral feeds, but he is having hypertension with hypokalemia. What is the action of potassium in blood vessels?
Vasoconstriction.
Vasoconstriction. Okay. Now, how do you investigate this hypokalemia?
The lab, we need to check for urine spot potassium to see if there is renal wasting or the dietary loss.
Okay. So, what is the normal value of urinary potassium?
0 to 20 milligram.
20 milligram. Up to 20 milligram may be normal, but if you are taking more potassium in the diet, it can also lose through the kidneys. But when you have a hypokalemia, what is the action of kidney? When you have a hypokalemia,
kidney should actually conserve, so there should be low.
Okay, so there should not be any urinary potassium, or it may be very minimal. But here, what is the potassium level?
So urinary potassium is 46 points.
So that is very high. So due to some reason, this patient is losing potassium through the kidneys. There is no drug which can remove potassium through kidney, and he is taking adequate oral potassium, but still he is having renal loss of potassium. What do you do next?
Next, we need to calculate transtubular potassium gradient.
Okay.
In this case, it was coming to be more than 4.
Okay.
And apart from that, patient history, like if there is a hypokalemia with transtubular gradient greater than 4 and BP was in the higher side, we need to consider plasma aldosterone and plasma renin values.
So you have to check plasma aldosterone and plasma renin. Okay. If both are increased, same effect, it can remove potassium from your body. Either aldosterone or renin, both can remove potassium through the kidneys. So what happened to the plasma renin and aldosterone here?
Plasma renin and aldosterone on supine position, the lab values are within normal range.
Okay, so there is no increase in the plasma renin or plasma aldosterone. Suppose only plasma renin is increased, the problem is in the kidney. If only aldosterone is increased, then it is in the suprarenal gland. Here, according to your report, both are normal. But in endocrinology, you have to always repeat the test. Okay, one value will not, because it can be lab error, it can vary with your position, it can vary in labs. So one value alone will not give any better result. So you have to advise this patient to take a re-examine completely. Okay, whatever it is, here both are normal. So there is no correctable cause. We are not able to do any correction for this. We can only treat this patient. Okay, suppose there is a suprarenal mass, you can remove that, the BP will be completely under control. Okay, so what is the next thing? How do you manage this patient?
As a patient of like less than 40,
what ABG finding you can get in hypokalemia?
We can get metabolic alkalosis.
Metabolic alkalosis is the most common finding. Okay.
As this patient is an young patient with features of hypertension, we need to rule out young hypertension causes like any renal artery stenosis is there. Then primary hyperaldosteronism to be worked up further.
Okay.
And if sleep apnea also is one of the predominant causes of young patient.
Okay.
Patient was a thin built patient with no difficulty in sleeping. So all these three primary main causes have been ruled out.
Okay.
And regarding her hypertension, it might be because of her anxiety issues also. So we had given an anti-anxiety like Alprax was.
Okay. So the patient is having anxiety, so you had given a anti-anxiety medication like alprazolam.
Because her sleeping schedule was also not irregular. She's not getting full sleep, required sleep. Okay. And then regarding other drug-induced any hypertension, those causes weren't there.
What are the commonly used drugs can produce hypertension in a patient? Commonly used. Which commonly used
oral
drug?
Contraceptives are the
oral contraceptive pills are very important. Okay, then NSAIDs can induce. Then, so you have to ask all this history. NSAID, whether for a headache, whether she has taken NSAID, that itself can produce sometimes all this problem. Or whether the patient is taking oral contraceptive pills. Then any cold medicine can increase BP. Commonly available cold medicines, common cold medicine. Cetirizine will not increase. Cold medicine, cold. You are using multi-drug regime in cold. What all it contains? Phenylephrine, pseudoephedrine. All these things can increase hypertension. And Otrivine, that is what is it? Nasal drops, that also can increase BP. Oxymetazoline. Okay. All these things you have to ask whether they are taking or not. Any other drug recreational drug can increase the BP? Question, it is very common. What is a recreational drug can increase BP, ECG changes, arrhythmias? Amphetamine. Amphetamine is very common nowadays. So that also you should take a detailed drug history, whether this patient is having any other drugs or recreational drugs. All these things are very important. Okay. Any ECG changes in the?
No ECG.
What is the importance of ECG change?
To see if there is any LVH changes, then we can say it's over a prolonged time.
So LVH is there means it is an ongoing, prolonged or long-term process. If it is not there, it may be a short-term problem. We can control it easily. Okay.
2D echoes also was done to evaluate for this same. There was no any LVH changes. But when ophthalmological evaluation was done, there was grade 1 hypertensive change noted in the fundoscopy.
Okay, that means she is having some problem. Why we are looking at the fundus?
To see, because of the hypertension, retinopathy changes.
Let it be there. What is the problem?
Long time, because
time we can know.
If it is not being controlled within normal range, there will be rapid.
What is your idea about looking at the fundus?
Field effects will happen.
Field effects fundus is it is not required. No? Why we are looking at the fundus? Because this is the only area you can visualize your blood vessels. So So whatever change you are seeing in your eyes, that change can be there in your brain, that change can be there in your kidney, that change can be there in your heart. So microvascular changes because of hypertension, diabetes, all can be picked up in your eyes. So that is the marker which can tell you that this person's kidneys are affected. Okay, so you have to treat for that also. So you have to prevent kidney disease by adding some drugs in this patient. So that we'll discuss after. So fundus examination is very important. That is the area you can visualize your blood vessels. So the same change can happen in an organ like kidney. That is very important. Okay. So now fundus changes are there. What renal function test you want to see whether the patient is having kidney disorder or not? Creatinine may be normal.
No.
What else?
Kidney electrolytes.
Microalbumin. So you have to check for microalbumin or urine creatinine albumin ratio. That also can be done. So you have to rule out a early kidney disorder in this patient. Okay.
And regarding other...
What is the age of this patient?
37-year-old.
She is a young female patient who is having hypertension with fundus changes. You want to rule out any immune-mediated disease?
Immune-mediated like SLE?
SLE is one of the important conditions where the patient may not have systemic, clinical manifestation of SLE, that skin changes may not be there. So after sometimes patient can come with florid SLE-like features. So you have to rule out a SLE also in this type of patient, young female with hypertension. That is not very common in clinical practice. Okay. And hypothyroid, some hyperthyroid.
Thyroid workup was also done, but on ultrasound of the neck, it was showing chronic thyroiditis nodules.
But T3, T4 are normal. TSH is also
normal. So clinically, it was not significant.
Okay.
Further, the patient was given, started with a calcium channel blocker.
Okay.
Of 10 mg.
So now you have to tell me how to select antihypertensives in a patient.
Yes.
How to select which are the first line drugs in antihypertensive therapy?
First line agents would be calcium channel blocker.
What is the first line agent?
AC.
AC inhibitor, ARB.
ARBs.
Okay, second line or along with other class of drugs which can be added as a first line therapy. What are the other? Calcium channel blockers. Then
and beta blockers.
Diuretics. Previously it was ABCD rule. AC inhibitor, ARB. B is beta blocker, C is calcium channel blocker, D is diuretic. Now it is only B is not there, ACD rule. Okay. So B unfortunately it is not. It is removed from your first line of treatment. Where we use beta blocker?
When there is heart failure.
When there is coronary artery. CAD is the absolute indication for starting a beta blocker as a first line therapy. Here it is not there. So you can start AC inhibitor, ARB, something like that. So which one you prefer in this case? Which one you prefer in this case? You tell me which is the most important drug.
Hypokalemia is there, so AC inhibitors.
AC inhibitor, what is the action on potassium?
Spare the
potassium. It can, so AC inhibitor or ARB can be started because it can even spare the potassium loss. But you can use some diuretics like potassium sparing diuretic also can be used here. Okay. But you are directly started on
calcium channel blocker.
What is the action of calcium channel blocker in this condition? Is it really helpful or maybe helpful?
Maybe helpful.
Huh? Is it really helpful or maybe helpful? You have to tell me that.
Acts on the vessels.
It reduces the BP. That definitely it reduces the BP.
Like with cause of the BP was systemic, as there was no any.
That I understood. But what is the problem here? Here the young patient who is having hypokalemia, hypertension, the ideal choice will be AC inhibitor, ARB or your diuretic. That will be the ideal choice. But you have started calcium channel blocker, there is no contraindication. But if the patient is still having hypokalemia, you will have to add another drug. That is the only problem. So you have to address that also. This patient is losing large amount of potassium through the kidneys. Maybe some defective problem is there in the kidney, we don't know. You have to evaluate that in detail afterwards. Okay. After that, what happened to the BP?
BP has been controlled to ranges of 130/70. Sir.
Potassium?
Potassium correction was given actually 40 milliequivalents during a day and started on coconut water and increased potassium rich diets.
Okay, what are the diet which is rich in potassium?
Coconut water is,
Coconut water is
and
rich.
then lime juice,
Lemon juice.
green leafy vegetables,
Okay.
milk.
Okay. What is the magnesium level in this patient?
Magnesium.
Is it important?
Yes, sir. Hypokalemia can be, if there is low magnesium, even hypokalemia can be there. Magnesium was 1.9, sir.
1.9 is near normal or a normal here in our lab. So if magnesium is low, what do you do?
First we have to correct magnesium.
Magnesium has to be corrected, then only your potassium will be
Correct.
corrected. Okay. Suppose this patient next time when she come back for a visit after 1 week, if the BP is not controlled, what do you do?
Then we need to change the.
What do you do?
First, check the potassium levels.
Okay, potassium level has to be checked, definitely. But when will you add another drug to the regime? That is very important. So today you have started calcium channel blocker. You have started which drug?
Clinidipine.
Cilindipine. Okay. When will you add additional drug or when will you increase the dose?
After the half-life, 2 weeks of half-life.
2 weeks. So only after 2 weeks you do some action. No need to check the BP every day. No need to start another drug in between. No need to increase the dose. You have to wait for 2 weeks, and after 2 weeks, if it is not getting controlled, if the treatment is not optimal, you can increase the dose of cilnidipine or you can add additional drug. Both are having equally and same effect, and combination of drugs will have better, like some areas it will have a better control. That's all. So this patient is having retinopathy. How do you follow up? When will you follow up?
Every 1 year we can follow it up.
Okay.
But as per the AHA guidelines, young onset hypertension, the 10-year curves, like progression of the retinopathic changes, kidney changes, there is no any significant hard and fast rule about them. So there is no specific guidelines regarding them. Regarding the other patients, as we have every 1 year kidney test.
Can you tell something about J-curve response?
If there is a patient having higher BP during the initial childhood only, then as per the curve it will be at the higher end even as the age increases.
Then?
So that is a system, like.
There is something regarding your treatment also. What is that? So you have a patient who is having high BP who is coming to emergency room. Will you give a medicine which can reduce the BP rapidly? And if you reduce the BP more than 50% of the stat BP which is done in your ER, what will happen?
Then there can be ischemia to the other parts of the brain.
That is one. That is a type of J-curve response. Okay. When you reduce small amount from that basic BP, more than 25%, the complication will be very high. That is because all your internal organs are set for your high BP, and suddenly you are reducing your BP by giving sublingual tablets or intravenous drugs. And BP, when it is reduced, the internal organs, especially kidneys and brain, that can develop ischemic problem, and that produces more damage. Okay, that's why you are not supposed to reduce the BP very fast in emergency room unless until there is a dire emergency like intracranial bleed or pulmonary edema, like that. Here it's a patient who is having a high BP, but she is stable. So you can take more than 24 hours to reduce the BP to 25% of the existing BP, and slowly it has to be reduced. So that we have to keep in mind. They never give sublingual or drug. Nifedipine. Sublingual nifedipine is the most commonly misused drug in emergency practice. So any patient coming with doctors give sublingual nifedipine. That immediately crashes the BP and patient can develop complication. Okay. If the patient is having pulmonary edema, what is the best drug? High BP with pulmonary edema.
Titrating it with the nitroglycerin.
NTG. You give Lasix and NTG. Okay. The patient is having pregnancy with high BP. If the patient is having pheochromocytoma with high BP,
alpha plus beta blocker.
First alpha blocker, then beta blocker. Or you can give labetalol. That has got both action. So almost all conditions we can use labetalol except in
COPD.
COPD can be COPD, asthma, it may produce complication. Otherwise, you can give in almost all conditions. Okay, thank you.